Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over, her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
your left
hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. Today, we are tackling a beast. And if you're a nursing student or maybe a clinician who's brushing up on pediatrics, you know exactly what I'm talking about.
Oh, yeah.
We're talking about the infant year.
It is a massive topic. It's sort of the Everest of the pediatric curriculum.
It feels so overwhelming. I was looking through the stack of sources for this. We've got the ATI pediatric nursing texts, growth charts, vital signs protocols, a developmental theory from Piaget and Erickson. And honestly, at first glance, it just feels like you're trying to memorize
A phone book.
a phone book. Exactly. It's just rows of data. At 2 months, they do this. At 4 months, they do that. At 6 months, they eat this. It feels totally random.
It does.
They're just trying to cram these lists of reflexes and weights into your brain before an exam, hoping you don't mix up the Moreau reflex with the Babinski. It feels like there is no logic to it, just a series of isolated facts.
And that is the trap. That is the rote memorization trap, 100%. If you try to memorize every single bullet point in a pediatric textbook as its own little island, you are going to burn out. And honestly, you're probably going to miss the critical questions on the exam because you aren't seeing the pattern. You're looking at the trees, but the exam questions and the real-life babies, they're the forest.
So what's our strategy today?
Right.
Because we promised an 80-20 guide.
Right. The Pareto principle.
Right.
We are going to focus on the 20% of the concepts that explain 80% of what happens clinically.
Okay.
We aren't just going to list milestones. We are going to look at the why. We're going to integrate the physical growth with how they think, that's Piaget, and how they feel, that's Erickson.
So instead of just saying keep the crib rails up, we're going to explain the biological mechanism that makes the crib rails necessary at a specific month.
Exactly. If you understand how an infant moves and how they process information, you don't need to memorize the safety risks.
And can predict them.
You can predict them. You can walk into a room, look at a baby, and know exactly what they're about to try and do to hurt themselves.
I love that. Predicting instead of memorizing. So our mission today is to take a deep dive into the infant from birth to 1 year and build a logical framework for all those cute baby moments so you can actually use them in a clinical setting.
Let's do it.
Okay, let's start with the big picture. Before we get into the nitty-gritty of what happens at month 4, we need to understand the theme of this entire year.
Right.
If you had to put a title on the first year of life, what is it?
The theme is rapid growth and integration. This is the fastest a human being will ever grow after birth. It is explosive. Wow. It's metabolic chaos in the best way. And for a nurse, that growth isn't just about clothes not fitting. It's about metrics. We call these the rules of thumb.
Okay, give me the cheat codes. Because on an exam, you get these scenarios like a baby weighed 7 pounds at birth. How much should they weigh now? And you have to do the math.
Precisely. So here is the golden rule for weight. And this comes straight from the growth monitoring protocols. An infant's birth weight should double by about 4 to 6 months of age.
Doubled by 6 months. That seems incredibly fast when you think about adult weight gain.
It is. I mean, imagine if you doubled your weight in 6 months. It's metabolically demanding. It requires an immense amount of caloric intake relative to their size.
And what about by the end of the year?
And then by 12 months, that birth weight should triple.
Tripled by a year. So let's play that out. If I'm born at 7 pounds.
You're looking at around 14 pounds by that 6-month mark and 21 pounds by your first birthday.
Okay.
Now, why does this matter clinically? Because if a child is significantly under that, we're looking at failure to thrive, malnutrition, or maybe a cardiac issue, burning too many calories. If they're way over, we are looking at obesity risks.
So they're not just trivia numbers?
Not at all. They are the primary indicators of health.
What about height? Or I guess we call it length, since they can't stand up yet.
Right. We measure crown to heel length. The rule there is that it increases by about 50% by 12 months. So they are getting longer faster than you might expect. They are stretching out.
Yeah.
But the really interesting metric, And the one that freaks parents out sometimes is the head.
The head circumference. I feel like every parent stresses about the percentile of the head.
They do, but for us, it's about intracranial dynamics. In the first year, the head circumference grows by about 10 centimeters. That is massive structural expansion.
Wow.
And there's a physiological reason for that.
Yeah.
The brain weight doubles by 6 months of age.
Wait, say that again? The brain weight doubles in just 6 months.
It does. That's why the head is so big compared to the body. It's housing this rapidly expanding supercomputer.
So the skull has to be able to accommodate that.
Exactly. The skull can't be fused shut yet. If the skull was a solid bone helmet like ours, the brain would get crushed.
Hence the fontanels, the soft spots.
Exactly. They're basically expansion joints. They allow the plates of the skull to shift during birth to fit through the canal, and then they allow the plates to spread apart as the brain grows.
And this is a classic exam question. When do they close? I always get these mixed up.
It's so easy to mix them up, so let's separate them. You have the posterior fontanel, that's the one on the back of the head.
Okay.
That one is smaller, triangular usually, and closes pretty quickly, usually by about 2 months of age.
Okay, posterior by 2 months, back of the head, closes first.
Then you have the anterior fontanel, the big diamond-shaped one on top. That stays open much longer to allow for all that brain growth we just talked about.
Right.
It closes between 12 and 18 months.
12 to 18 months, got it. So if you have a 6-month-old with a fused anterior fontanel, that's a problem.
Big problem. That's craniosynostosis, premature fusion. It can restrict brain growth and require surgery to reopen the sutures.
And on the flip side?
On the flip side, if you have an 18-month-old and it's still wide open or bulging, that could be hypothyroidism or increased intracranial pressure. The fontanel is like a window into the brain status.
Now, you mentioned integration as part of the theme. I want to talk about the direction of this growth. Because I remember reading about cephalocaudal and proximidistal, and those sound like fancy Latin words that are easy to gloss over.
They are fancy words, but they are the Rosetta Stone for motor skills. If you understand these 2 words, you don't need to memorize the order of milestones. It becomes obvious.
Okay, break down cephalocaudal for us.
Cephalocaudal literally means head to tail. Cephalo is head, caudal is tail.
Head to tail. Simple enough.
Oh, it means neuromuscular control starts at the head and moves down the body. Think about a newborn. What is the floppy part?
The head.
The head. The very first thing they have to learn to control is the neck.
Right. They can't do anything else until the neck is stable.
Once they get the neck, the signal travels down to the shoulders, then the trunk, then the hips, and finally the legs and feet. That is why a baby can lift their head way before they can sit, and they can sit way before they can walk. The software update installs from the top down.
That makes so much sense. You don't get the walking update until the sitting update is complete. It's a progressive download.
Exactly. And the second direction is proximidistal. That means center to out or near to far.
So from the core out to the fingertips.
Yes. Think about coordination. An infant can flail their whole arm using the shoulder and shoulder muscles months before they can control their hand.
Okay.
And they can use their whole hand to rake an object months before they can use their individual fingers to pick up a Cheerio.
Because the shoulder is proximal, closer to the center, and the fingers are distal, further away.
You got it. So when you see a question asking which skill comes first, waving bye-bye or picking up a raisin, you just ask yourself, which uses muscles closer to the center?
Waving. That's mostly arm and wrist.
Waving is mostly arm wrist. Picking up a raisin is fingertips. Waving comes first.
Okay, that is the roadmap. Head to tail, center to out. Let's apply this. I want to walk through the timeline, looking at what the child can do and cannot do at key stages. Let's start with the 2-month-old.
The 2-month-old is squarely in that head stage of cephalocaudal development.
So what are we seeing physically?
Well, if you put them in a prone position on their tummy, they can lift their head up a bit off the mattress. It's a huge milestone. It means the neck muscles are coming online, but they cannot support themselves sitting. If you pull them up to sit, the head lags behind. That head lag is very prominent.
What about socially? Are they interacting yet?
This is the sweet spot for the social smile.
Yes.
Around 2 months, they start smiling back at you purposefully. Before this, a smile usually meant gas.
Right.
Now it means connection.
But despite that smile, they're still dominated by reflexes, right? The source material lists a whole bunch. Moro, rooting, suck, tonic neck.
Yes, and this is crucial for the 80-20 learner. We tend to think of reflexes as just things babies do, but clinically they are placeholders.
Placeholders.
Primitive reflexes like the morostartal reflex where they throw their arms back, or the rooting reflex where they turn toward a touch on the cheek are involuntary. For voluntary movement to take over, these reflexes must disappear.
They have to go away.
They have to. Think about it. You can't voluntarily grab a toy if your hand automatically clamps shut every time something touches your palm. That's the palmar grasp.
Right.
You can't learn to roll over efficiently if your arm shoots out in a fencing position every time you turn your head, which is the tonic neck reflex.
So, seeing these reflexes fade is actually a sign of neurological maturation.
Exactly. If a 12-month-old still has a strong moro reflex, that's a red flag for cerebral palsy or other neurological issues. The voluntary system hasn't taken over. It's like the operating system failed to update from beta to live.
Okay, moving on. Let's go to the 4 to 6 month window. I feel like this is where things get active.
This is the roller stage. And some distinct things happen here regarding rolling.
The sources are specific on the direction of the roll. Which comes first?
Typically, an infant rolls from prone, so tummy, to supine, which is on their back, around 5 months.
Okay.
It's a bit easier to push up with those developing arm muscles, and then gravity kind of helps you flip over.
Right.
Rolling from supine, so back, to prone, which is tummy, usually happens a bit later, around 6 months, because it requires more abdominal control to fight gravity and flip onto your stomach.
So back to front is harder.
Correct. And developmentally, they're also starting to sit, but it's the tripod sit.
The tripod sit.
By 6 months, they can sit alone, but they have to lean forward on their hands to prop themselves up. They aren't fully upright yet. The trunk update isn't quite finished.
What about their hands? Proxima distal says they should be getting better control.
They are. They can hold a bottle with 2 hands now, bringing the hands to the midline. They can bat at objects, and they bring everything to their mouths.
Of course.
That center-to-out control has reached the palms.
Which brings us to the 9-month-old. This feels like a huge turning point in the notes.
The 9-month-old is the mobile explorer. The biggest gross motor milestone here is sitting unsupported, no hands on the floor.
That's a big one.
They sit upright, their back is strong, and they can turn to play with toys.
And they aren't stuck in one place anymore.
No, they are crawling. Some are pulling to a stand against the coffee table. They're realizing the world is accessible.
Oh.
But the most critical update here, the one that changes safety risks entirely, is in the hands. This is the debut of the pincer grasp.
The pincer grasp. Why is this so significant?
It starts as a crude pincer grasp at 8 or 9 months. This means using the thumb and maybe 2 fingers to rake or grab a small object. Before this, they just used the whole palm like a claw machine. Now they can pick up smaller things.
Which sounds great for feeding, but terrifying for safety.
It changes the entire safety landscape. We'll get to that. But yes, suddenly the lint on the carpet, the button that fell off a shirt, it's all accessible.
Finally, the 12-month-old.
Yeah.
The birthday boy or girl.
The vertical child. By 12 months, they're usually walking with help or cruising, shuffling along the furniture, holding on. Some might take their first independent steps.
And the hands. Has the pincer grasp changed?
The pincer grasp becomes a fine pincer grasp. They can pick up a single Cheerio with just the thumb and index finger. Precision.
Wow.
They can also put objects into a container.
That's a skill, putting things in a box.
It is. It requires releasing the grasp voluntarily. Before this, letting go was hard. The reflex to hold on was stronger than the command to let go. Now they can drop a block into a bucket. It demonstrates high-level motor planning.
Okay, so we have a physical roadmap, head up, roll over, sit, crawl, walk. But I want to switch gears to the brain, because you can't separate the body from the mind. How are they thinking during all of this?
This is where we bring in Jean Piaget. For the first 2 years of life, the infant is in the sensorimotor stage.
Sensomotor. The name kind of gives it away.
It does. They learn through senses and motor movement. They are not logical beings. They are experimental beings. They don't think, if I push this button, the light goes on. They just mash the button and see what happens.
So there's no abstract thought yet, no planning.
Not really. They are reacting to stimuli, but there are 2 massive cognitive aha moments in this year. The first one is cause and effect.
Like shaking a rattle.
Exactly. Piaget calls these secondary circular reactions. Around 4 to 8 months, the baby shakes a rattle and hears a noise. Their brain goes, wait, I did that. If I do this motion, that sound happens, and they do it again.
And again.
And again. They are realizing they have agency in the world.
That's pretty powerful. The first step toward tool use, really. What's the second concept?
The big one, object permanence.
The ghost concept.
This is huge.
Yeah.
Imagine for the first roughly 6 to 8 months of your life, out of sight literally means out of mind. If I show you a toy and then put it behind my back, to you, it didn't just disappear. It ceased to exist.
The universe deleted it.
It's gone.
So when mom walks out of the room,
She dissolves. She's gone forever. That is the infant's reality. But around 9 months, this changes. They realize that objects and people continue to exist even when they can't be seen.
and the notes say this explains why peekaboo becomes funny.
Yes. Before object permanence, peekaboo is just confusing. Mom's gone. Oh, she's back. It's startling.
Right.
But once they have object permanence, there is tension. I know she's behind those hands. I'm waiting. There she is. It's a game of confirmation. They are testing their hypothesis that you still exist.
That leads us perfectly into the emotional side. Because if I know mom exists, but I can't see her, that feels like a recipe for anxiety.
And that is exactly where Piaget meets Erikson. This is the integration we talked about. You cannot separate the cognitive development from the emotional crisis.
So Erickson's stage for this year is trust versus mistrust.
Correct. The fundamental goal of the first year of life is to answer one question. Is the world a safe place?
And how do they decide that?
By whether their needs are met. When they cry, does someone come? When they are hungry, are they fed? When they are wet, are they changed?
Okay.
If the answer is consistently yes, they develop trust. If it's inconsistent or neglectful, they develop mistrust.
There's a really interesting nuance in the source material about spoiling. I feel like grandmothers everywhere are always saying, don't hold that baby too much, you'll spoil him.
The clinical evidence says the exact opposite. You cannot spoil an infant in the early months. In fact, meeting those needs, immediately responding to the cry, is what creates the foundation of trust.
So by holding them now, you're actually making them more independent later.
Yes. It's counterintuitive, but think about it. If they have that solid foundation of trust, they can tolerate small delays later on. They learn delayed gratification because they know you will come back.
Right.
If they don't trust you'll come back, they scream the second you leave.
Okay, so let's connect this to the anxiety. We have object permanence kicking in around 9 months. We have trust versus mistrust. Why does separation anxiety hit so hard between 4 and 8 months?
It's the perfect storm. Think about the formula. I now have the cognitive ability to know you exist when you leave. That's object permanence.
Right.
But I am completely dependent on you, and I don't have a perfect sense of time. That's the mistrust dependence part.
So when you leave, I know you're somewhere, but I don't know if you're coming back.
Exactly. Mom exists, but she isn't here. That gap creates the anxiety. It's actually a sign of healthy attachment and cognitive growth. It means they remember you.
That's a good point.
If a 10-month-old doesn't care when the primary caregiver leaves, that can actually be a sign of attachment issues.
And stranger fear. That hits around 6 to 8 months too.
That's linked to the ability to discriminate. Earlier, a baby might smile at anyone, but by 6 months, they can clearly distinguish between familiar and unfamiliar faces.
So they know you're not their person.
They realize you are not my person, and they protest.
So if you're a nurse walking into a room to examine a 9-month-old, don't expect them to be thrilled to see you.
No, you are a threat. The best strategy is to talk to the parent first. Ignore the baby for a minute. Let the baby see the parent trusting you. Don't swoop in. That stranger anxiety is a protective mechanism.
This brings us to the most practical part of the episode, safety. And I love how the outline puts this. Safety risks are not random. They are the result of the milestones.
This is the core of the 80-20 approach. If you know the milestone, you know the risk. You don't need to memorize a safety checklist. You just look at the baby's capabilities.
Let's play cause and effect.
Yeah.
I'll give you the risk, you give me the developmental why. First up, aspiration and choking.
The developmental cause is the pincer grasp at 9 months plus the oral fixation. Remember Freud, the oral stage?
Oh, yeah.
They explore the world with their mouths.
So they can pick up tiny things now, and their instinct is to put everything in their mouth to understand it.
Correct. Before 9 months, they couldn't pick up a coin or a button. Now they can. So the safety rule is no grapes, no coins, check the buttons on clothing. If it fits in a toilet paper roll, it's a choking hazard.
Next risk, falls.
This links to gross motor skills. Rolling over happens suddenly around 4 to 6 months. Pulling to a stand happens around 9 to 12 months.
And the problem is, parents don't know the baby can do it until they do it.
Exactly. The baby has never rolled over until the second you turn your back to grab a diaper.
Ugh.
That's why the rule is, never leave a baby alone on a changing table, even for a second. Keep a hand on them. And for cribs, The mattress must be in the lowest position by the time they can pull up to stand, or they will vault out of it.
Burns. This seems broad.
This is cognitive. They have no cause and effect reasoning for danger yet, and they have sensory curiosity. They want to touch the hot cup of coffee because it has steam. They want to turn the faucet handle because it's shiny.
So the environment has to be passive protection.
Right, you can't lecture them. Turn the pot handles toward the back of the stove. Set the water heater to below 49 degrees Celsius or 120 Fahrenheit.
That's a big one.
You cannot teach a 9-month-old not to touch hot things. You have to remove the hot things.
Motor vehicle safety. This is a big one for parent education. Rear-facing car seats. Why are we so strict about this?
The rule is rear-facing until age 2 or until they max out the height and weight limits. But the why is anatomy.
Is the big head?
It's the big head. An infant has a disproportionately large, heavy head and very weak neck muscles.
Right.
In a frontal crash, which is the most common type, if they are forward-facing, the momentum throws that heavy head forward. It's whiplash on steroids. It can literally sever the spinal cord.
That is a terrifying image.
It is. But if they are rear-facing, the back of the car seat acts like a catcher's mitt. It cradles the head, neck, and spine, distributing the force along the entire back. It's just physics.
Last safety point. SID. Sudden infant death syndrome.
The Back to Sleep campaign, we put babies on their backs, and the rationale goes back to that 2-month milestone, head control.
Meaning they don't have it yet.
Exactly. In the early months, if a baby is face down on a soft pillow or blanket and their airway gets blocked, they physically cannot lift their head or turn it to breathe. They suffocate.
So, no pillows, no bumpers, no stuffed animals, firm mattress, back to sleep.
Until they can roll over independently. Once they can roll, they can find their own position, but you always start them on their back.
Let's shift to something more fun, play. How do we play with these tiny humans?
Well, socially, they are solitary players. They don't play with other kids. If you put 2 8-month-olds together, they will ignore each other or maybe poke each other like objects.
Right.
They play near others, but focused on their own toy.
And picking the toy is just matching the developmental skill, right? Let's run through the ages. Birth to 3 months.
They can't grasp well, and their vision is still developing. They love high contrast, so. Mobiles, mirrors, music boxes. It's all about auditory and visual stimulation.
3 to 6 months.
Now they are batting at things, and the grasp reflex is fading, being replaced by voluntary holding. Rattles are perfect because they are easy to hold and bonus cause and effect.
The shake, it makes noise.
Exactly. Soft stuffed toys are good too.
6 to 9 months.
This is the teething phase and the social interaction phase. So teething toys are essential. Fabric books they can chew on. And games like Pat a Cake because they love that rhythm and interaction.
And finally, 9 to 12 months. The Mobile Explorer.
They are working on that pincer grasp and object permanence. So nesting toys like cups inside of cups are amazing for teaching things go inside other things. Large blocks. Push-pull toys to encourage that walking skill.
It's cool to see how the toy aisle is basically just a developmental psychology lab. A nesting cup is an object permanence lesson.
It really is. Every toy serves a neurological purpose.
Okay, we're heading into the final stretch. This is the exam writer's perspective. We want to give our listeners the edge on those tricky clinical application questions.
Let's talk nutrition first. The classic trap question is about cow's milk.
Can I give my 10-month-old regular milk?
The answer is a hard no. Not until 12 months. 3 reasons. 1, it's hard to digest and can cause microscopic GI bleeding. 2, it has a high renal solute load. It's hard on the kidneys. But 3 is the big one. It interferes with iron absorption. It puts the baby at risk for anemia.
Speaking of iron, that's also why we start solids at 6 months, right?
Yeah.
It's not just because they're hungry.
Correct. A full-term infant is born with iron stores that last about 4 to 6 months. By 6 months, the tank is empty. Breast milk is amazing, but it's naturally low in iron. So we introduce iron-fortified cereal first to replenish those stores.
And for allergies.
Introduce one new food every 3 to 5 days. Don't give them peas, carrots, and pears all on the same day. If they break out in a rash, you need to know which one caused it.
Next topic, pain assessment. This is tough because babies can't tell you it hurts.
Self-report is impossible, so we have to use observational scales. The gold standard for infants, so 2 months to 7 years, is the FLACC scale.
FLACC, face, legs, activity, cry, consolability.
You score each category 0 to 2. Are their legs kicking or relaxed? Are they arching their back? Are they crying steadily or just whimpering? Are they inconsolable? That gives you a number out of 10.
But what about a neonate, a brand new baby?
For them, we often use the CRIES scale. Crying requires oxygen, increased vital signs, expression, sleeplessness. It's more physiological because newborns respond to pain with heart rate spikes and oxygen drops more than behavioral acting out.
Okay, here's the one that stumps everyone. The math question regarding prematurity.
Adjusted age. This is so critical. If you are assessing a baby who is born premature, you cannot hold them to the standard milestones based on their birth date.
Right.
You have to adjust for the time they missed in the womb.
Walk us through the calculation. Let's say we have a 6-month-old baby girl, but she was born 2 months early at 32 weeks gestation.
Okay. Chronologically, she has been out of the womb for 6 months. That's her birthday age.
Okay.
But she missed 2 months of development inside. So we subtract. 6 months minus 2 months equals 4 months.
So her adjusted age is 4 months.
Right. And here is the exam trap. The question will ask, what developmental milestone should this child be performing?
And if you use her chronological age, 6 months, you'd expect her to sit unsupported.
Which she probably can't do yet. She is developmentally a 4-month-old. So you should be evaluating her for 4-month milestones. Head control, rolling over, maybe grasping a rattle.
That is such a key distinction. You catch up eventually, right?
Usually by age 2.
Yeah.
But for that first year, you have to do the math. Always do the math.
We have covered a massive amount of ground. From fontanels to object permanence, from pincer grasps to car seats. Let's try to wrap this up with our 80-20 summary box. What are the core takeaways?
Okay, if you remember nothing else, remember this logical flow.
Right.
1, if they can't move, they can suffocate. That's the SIDS risk in the first few months. 2, if they can move, they can fall or aspirate. That's the safety risk once rolling and pincer grasp kick in.
Makes sense.
And 3, if they know you exist but can't see you, they panic. That explains separation anxiety.
And the growth rules?
Weight doubles by 6 months, triples by a year. And head growth reflects brain growth, so check those fontanels.
And finally, the underlying philosophy.
Trust versus mistrust. Everything you do as a nurse or parent feeding, holding, comforting is building the neurological hardware for trust.
It really changes how you look at a baby. They aren't just sitting there.
Yeah.
They are running complex experiments on reality.
They are the ultimate learning machines.
I want to leave you with one final thought to chew on. We talk about how vulnerable these infants are born with almost no instincts other than sucking and rooting. They are completely helpless.
It is unique in the animal kingdom. Most mammals can walk within hours. Humans take a year.
Exactly. And that extreme vulnerability forces a deep connection with the caregiver.
It makes me think, maybe that helplessness is actually a feature, not a bug.
It forces that trust bond to be the absolute strongest force in human development. Without that initial total dependence, maybe we wouldn't form the deep social bonds that make us human.
That is a profound way to look at it. The dependency creates the humanity.
Something to think about next time you're checking a diaper or plotting a growth chart. Thank you for joining us on this deep dive into the infant year.
Keep learning.
We'll see you next time.